We are doing a deep dive on IBS with dietitian Meghan Donnelly. Meghan has worked with me as the lead dietitian for Skinny 60 for 7 years now, and she's been on the podcast many times. She works in gastrointestinal nutrition in New York City and specializes in IBS and SIBO and other digestive conditions. She is a certified FODMAPs practitioner and the director of health communications at the Celiac Disease Foundation. And Meghan and I have led many cycles of our 60-day reset together. And what I love about her is that she meets every person where they're at and always finds the least restrictive protocol to get results while maintaining a joyful and balanced relationship with food. So in this episode, we're going to cover the causes of IBS, the symptoms, the different types, how to get diagnosed and what treatment might look like, the most common mistakes that people make, and the differences between IBS and IBD and SIBO, Crohn's disease, and other digestive conditions. So if you have IBS or have persistent gas and bloating or abdominal pain and suspect that you might have IBS, I'm really excited for you to get this information. So let's dive in and get the skinny from Meghan Donnelly. Meghan, I am excited to do this deep dive on IBS with you because it affects so many people and we get so many questions in our Skinny 60 community, and it's been a long time coming. So let's start with what IBS is.
Yeah, so it's a very common functional gastrointestinal disorder that it basically is characterized by problems with gas, bloating, and bowel movements. And it is one of the most common things that I see as a GI dietitian. We are in a society where so many people are living with this chronic condition and they don't know what to do about it because there's so much information out there that is not accurate and actually harmful in contributing to symptoms.
Yeah, and when you say gas, bloating, abdominal pain, dear listener, you might be going, oh, I have IBS then, because so many people have gas, bloating, and abdominal pain regularly. So let's talk about, first of all, I want to ask you why you've made this one of your particular areas of specialty, because you treat so many people with IBS, and why you went into digestive diseases as a dietitian when you could have gone into anything.
Yeah. I mean, I sort of ended up with an IBS specialty out of necessity. It seems like the most common thing that I get referrals for, the
Wow.
most common thing people reach out about. And so many of the symptoms overlap with other conditions that when you're working in any sort of digestive disease, it seems like we come back to treating these same symptoms in a lot of different groups, which means you kind of have to learn as you go. And I was fortunate enough to have some really good training early on in my dietetics journey, and so yeah, it just kind of ended up that way. But I've had so many patients and clients over the years who have come to me saying, I can't go anywhere. I can't
Mm.
travel. I can't eat out. I need help. I'm so afraid that if I go anywhere, I'm going to have to go to the bathroom. And that really
Yeah.
motivates me as a dietitian to help, because that is one of the worst things ever, not being able to eat when you leave your home because you're
I
afraid of.
know food is one of the great pleasures of life. We want to be celebrating and dining out with friends and family and eating what we want and feeling great about it, not feeling terrified. Let's talk about these numbers because they really are alarmingly high. So what is the prevalence? How many people are estimated to have IBS?
Yeah, in the United States, and this is similar globally, but we tend to see higher rates in more Western societies where there's a higher intake of processed foods and higher stress and all of the things that we know are not great for our health. But it affects about 10 to 15% of the population, which is massive.
I, I mean, that's millions and millions and millions and millions of people. So where do we get the 10 to 15? Let's talk about this change of the 5%. Is this people that just don't know that they have it? Where do you get that range from?
Yeah, I mean, there's always some overlap with other things going on. So sometimes people, if they have another condition like celiac disease or inflammatory bowel disease, for example, and they don't know that they have that, but then that gets treated and their IBS, which maybe they had or maybe they didn't really have, kind of goes away. So there's a lot of things like that. And then it does seem like IBS is more common in women. That is pretty much true across the different studies that we see, but we don't totally know why. We can get more into that later on in the
Oh,
conversation.
I'm going to ask you about that. Yeah.
Yeah, I mean, I think it's important too to think about all the hormonal transitions that women go through, and could that be contributing to why, someone might have something going on earlier on in their life or later in their life, and then it changes as their life cycle changes. So I think there's a number of reasons for the shift. I also think some people learn how to manage their symptoms really well, and while they still maybe have IBS, they're not really actively experiencing the symptoms. So
Yeah. Oh, I'm going to ask you about that too, because that is something we see all the time in our community, don't we? Let's talk about how we know that we have it, diagnosis, and the fact that there's no biomarker.
yeah, it makes diagnosis challenging. I mean, IBS is diagnosed based on symptoms. There's no blood test. It's not going to show up in your colonoscopy. It's not going to show up in your endoscopy where you get a biopsy of your small intestine. And this takes an emotional toll on people. I mean, people are told very often it's all in your head, or, they get very discouraged because they get all these tests back that say everything's normal. And sometimes the psychological stress of that exacerbates the symptoms.
So what is the diagnostic criteria then, where you would say you've got IBS?
Yeah, so the key thing really is abdominal pain associated with change in stool frequency and texture. So this has to be ongoing. You don't just have IBS if you have a week or two where you're constipated or you're experiencing loose stools and then it kind of resolves itself. IBS is chronic, so usually the criteria, like the cutoff point, is 3 months of having these symptoms every week. And
once a week, twice a week, sort of what would you say?
Yeah, I mean, at least 1 day per week. And the abdominal pain tends to be associated with gas and bloating, and then it can very clearly be exacerbated or helped by having a bowel movement. So sometimes with people with looser stools, they might feel that pain with their bowel movement, but then it sort of gets better, and constipation similar. Like the symptoms improve typically when someone has a bowel movement. So a doctor is going to look at your symptoms. They're going to check your blood work to test for like anemia, other inflammatory markers. Hopefully they're ruling out other conditions like celiac disease or inflammatory bowel disease. Sometimes they're doing a colonoscopy just to make sure everything's normal on that front. I mean, especially if someone's over 45, it's really important that they're getting a colonoscopy so that they make sure that this is not cancer or any other type of colon condition. And then they're going to really listen to your symptoms and make a determination. So that can take a while. Sometimes all that workup it can take months, and that's
leads into the more of the frustration too.
Yeah,
I don't even know what I've got. I need a label. I need to know. I need a diagnosis. I just want to know what I've got.
Yeah.
And it really can lead into anxiety and depression and social anxiety, all the things that we talk about. You talked about other disorders, and we sort of do it by a process of elimination, often with diagnoses. Let's talk about some of the disorders or the diseases that IBS is not, that you could have, that have these crossover symptoms.
Mm-hmm. Yeah, I mean, the big ones that we always look out for are celiac disease, Crohn's disease or ulcerative colitis, and colon cancer. These are distinct conditions, but someone could have IBS on top of these conditions. And so sometimes we are managing multiple things that requires medication intervention or other diet restrictions or something like that. It really is a crossover condition. And we see that people with existing GI conditions can have increased risk for IBS. And why? It's probably just because the intestines are inflamed, but we don't totally understand the connection at this point.
So you could have IBS and one or two of these other things.
Yeah, absolutely.
Therein is a labyrinth of testing, diagnosis, all kinds of stuff. Oh, yeah. So talk me through the symptoms to look out for. You talked about the gas, the bloating, abdominal pain. Is there anything else that we need to be looking out for that might indicate that we would have IBS?
Yeah, I mean, those are the biggest things. Sometimes we'll look for diarrhea or constipation or a mix of both. Sometimes people have kind of alternating diarrhea and constipation. Urgency, so having to go to the bathroom really quickly without much warning. Being unable to completely evacuate the colon. So when you feel like there's more stool in there, but you can't push it out. Sometimes having mucus in the stool. Any sort of bowel movement alteration can be an IBS symptom, but gas and bloating and abdominal pain are pretty much always present to an extent.
So when we're, using Google or ChatGPT, I say we, but we don't recommend anybody do that for their health. But that is what a lot of people are doing, is they're checking for symptoms and they're Googling late at night because they're frustrated, they don't know what's going on. Can you talk me through some of the symptoms that would not indicate that I have IBS, let's say?
Yeah, waking up in the middle of the night to have a bowel movement, blood in stool. If you ever have blood in stool, you need to get that checked out by a doctor immediately. Unexplained weight loss, anemia, fever, all those would not be signs of IBS. And so sometimes what people, if they've had IBS for a while, they might have the symptoms of an IBS flare where they have really significant symptoms, but it's not actually related to their IBS. It could be related to some sort of infection or something, and they ignore these other red flags, and that is dangerous potentially. So yeah, any of those red flag symptoms I mentioned, you want to seek medical attention immediately.
Oh, let's talk more about these red flags and some of the other mistakes that we might make while we're searching for answers.
Yeah, I mean, I find that self-diagnosis is a massive problem. Sometimes people they go online and they think their symptoms meet this criteria and they treat it a certain way, and they'll go on a restrictive diet, or they'll take a random supplement, or they'll start taking all kinds of fiber supplements or something like that. And it's completely the wrong intervention for them. So it's very misunderstood. And I really, getting the right diagnosis is so important in terms of how we can actually treat what's going on. So even if someone has symptoms that look like IBS and they try something and they feel a little bit better and they think that's good enough, it's really not, because you could be missing something else, right? If you have symptoms that improve when you cut out certain foods from your diet, but then you develop vitamin and mineral deficiencies, or you're not meeting your protein needs, or your gut microbiome is disrupted because you're on a restrictive diet, that's not actually a helpful intervention. It could hurt you more in the long term. So really, I do not recommend people try to figure this out by themselves. They need to be working with a healthcare team that really understands the digestive system and what's going on.
Yeah, it's alarming, isn't it? The statistics now of how many people are using ChatGPT as their doctor and having a full-on conversation like they would be at the doctor with ChatGPT, which might be spitting out completely false information and is scraping from, websites that don't have reliable information. So you talked about the red flags in terms of symptoms. I want to talk about the family history piece of this and things to watch out for, looking at our family members and what they may have had in terms of how it might inform our predisposition for having IBS.
Yeah, I mean, it's always a good idea to look at your family members and what they've experienced in their health so that you can sort of understand what you might be at higher risk for. If you have a family history of colon cancer or inflammatory bowel disease or even celiac disease, these are things you want to bring up when you go to the doctor, especially if you have some of those red flag symptoms, but also any GI condition, because those things can inform, again, the level of seriousness of which the doctor is going to take what you're telling them and the testing that you might need to go through. You know, if someone has a family history of colon cancer and they come in with some non-specific gastrointestinal symptoms, a colonoscopy is indicated, right? Because you don't want to miss potentially early stages of some of these things. I see this, I work in celiac disease a lot, and I see this happen all the time where the family members never get tested, and then someone has something like blood in their stool and very bad digestive symptoms, and they never think to mention, oh, you should get tested too. And so it really matters. And so with IBS, every condition is somewhat, you do sort of have a predisposition for it if it's in your family, but IBS can mask something else. And if you're online looking for a diagnosis that matches your symptoms, you could be missing something like this.
Oh, I want to ask you more about celiac disease because you are the Director of Health Communications at the Celiac Disease Foundation in the United States. How many people do you estimate have celiac disease and don't know it?
Ooh, there are different estimates. We think in the United States it could be anywhere from 30 to 70%.
Wait, what?
I know.
I was not expecting you to throw out that large number. I almost fell off my chair.
Yeah, it's a huge range too, and it's because, you know, we don't really know who doesn't have something, right? So we're kind of estimating based on 1% of the population having celiac disease and making assumptions based on how many people we know are diagnosed. But yeah, it's a large amount of people. They call it the celiac iceberg, where there's all these people who are just living with celiac disease and don't know it. And I've had people working with me who get diagnosed when they're 70 years old, and it's kind of wild how long their symptoms went unnoticed.
Astonishing. And there's over, 200 symptoms of celiac disease, and so many of them are not gastrointestinal symptoms. Can you just talk us through some of the symptoms that we just might go, what? Like infertility is one, right?
Infertility, neurological issues like migraines or brain fog or neuropathy, which is like tingling in your extremities. It can affect your bone health. So sometimes early osteoporosis is the symptom.
Wow.
You name it, any system of the body can be affected with celiac disease. And so, yeah, it just goes to show you too how the intestines they're so important for your overall health, right? And celiac disease is where the intestines are affected and nutrient absorption is impaired. And so, but this could happen with any condition along the digestive tract, where you can have these kinds of symptoms that don't seem related, but very much are.
So, seen in a more prudential light, a diagnosis of IBS could reveal some other things that have been left undiagnosed for a very long time. We talk about this all the time. I call it a gift wrapped in dog shit, where it's uncomfortable, it's inconvenient, it might not be what you wanted or expected, but it can absolutely be a gift of knowledge that leads you into a better level, a higher level of self-care. You were talking about the gut-brain connection. We talk about this a lot together, and we have on other episodes of the podcast with you. And IBS is considered a disorder of the gut-brain connection. So let's dive into that a little bit more.
Yeah, so like I said before, there's no test where they're going to look in your digestive system and see any physical damage, because IBS is not causing structural damage in the traditional sense. Your gut-brain connection is either hyperstimulated or somewhat impaired. So, it's considered with this broader category of conditions where we're not just looking at the digestive tract. We have to look at the gut-brain connection and calming the gut-brain connection in order to really have an effective intervention. And so that's why we are oftentimes doing a number of things with our IBS people. We've got diet interventions, mental health interventions, sometimes medication management. It really is no one size fits all for anyone.
I want to ask you about the difference between IBS and IBD and celiac disease, and this idea of you're talking a lot about inflammation versus a structural damage issue.
Yeah, I mean, IBD, a lot of people get them confused. IBS stands for Irritable Bowel Syndrome. IBD stands for inflammatory bowel disease, and IBD has it has a few different subtypes, but the main ones are ulcerative colitis and Crohn's disease. And these are conditions where there's an inflammation happening at very specific points along the intestines, or any point in the digestive tract, actually, in the case of Crohn's disease. And so that's like a very clear inflammation pattern that happens where there's damage that can be physically seen. And that will also show up in your blood work when they test inflammatory markers. With celiac disease, it's an autoimmune condition that affects the villi of the small intestine. So the villi of the small intestine, which are normally grabbing onto your nutrients from food so you can absorb them, they become flattened. And so that nutrient absorption is impaired. And with celiac disease, again, when they go and do an endoscopy and they take samples of your small intestine, they can actually see that damaged area. So IBS is not like that. You're not going to go inside the intestines and find any points where they can pinpoint exact inflammation. Now, that doesn't mean there's not distress. We know there is distress. It's just different than what's happening with those other conditions.
Oh, those villi in the small intestine, they're like the superheroes of the body, aren't they? These little hairs of discernment. And we see this all the time, with people with digestive distress, the discernment that we see, or the lack of discernment. There's a direct correlation, but we could do a whole other podcast episode about that and the relationship between emotions and the gut and so forth. It's just fascinating. So there are subtypes of IBS, and they really do determine the treatment protocol. So let's go over those.
Yeah, so probably the one I see most often is IBS-D, which is a diarrhea predominant form of IBS, where you've got a lot of urgency and loose stools. IBS-C is kind of the opposite. It's constipation predominant, and so you're going to have infrequent bowel movements or straining or that incomplete evacuation that I mentioned before, where you feel like you can't get any more out, but you feel like there is still stool in the colon. And then there's a mixed subtype, which is a little bit tricky because it's kind of an alternating diarrhea and constipation pattern, and this is unpredictable and very frustrating for people that have it, because an intervention that might work sometimes doesn't necessarily work as well the other time. So sometimes with those people, we have to be really creative and to give them tools for both types of stool changes that they're having. So maybe they have a plan for when they're having more loose stools, and maybe a plan for when they're feeling more constipated, and they've got to adjust that. That one can take a little bit more time when you're working with someone with IBS-M.
Yeah. So what causes IBS?
Yeah,
Let's go back to the source for a minute.
Well, we don't totally know. We know certain things that can trigger it for sure. I mean, the gut-brain connection is certainly one of these things where in certain people, because of stress or trauma or foodborne illness, they've got a hypersensitive gut, and stress can amplify their symptoms and their pain signals, and their nervous system is overreactive. So there are people who they tell me, they went on vacation 5 years ago and they got a little bit of food poisoning and they've never been the same since then. Or, there's people who they had a traumatic event or some sort of long-term stress in their life that started, that's when their symptoms started. So sometimes people can pinpoint it, not always though, especially in children. We don't always know. But we do know that stress is a major trigger, and so we have to be addressing that when we're doing diet interventions.
Yeah, wow. I want to ask you about motility issues. You were talking about diarrhea before and how that may be a trigger for IBS, changes in motility.
Yeah, I mean, so motility really is just the rate at which food moves through your intestines. So if it's too fast, you could have diarrhea. If it's too slow, you could have constipation. If it's somewhat erratic, you could have the mixed subtype. And so motility, we always talk about it because we want to understand what is causing your digestive system to speed up or slow down. But it can be affected by a number of things: hormones, the types of foods you eat, how often you eat, what's going on in your environment, your stress levels. All those things can affect what's going on with motility. So it's not always straightforward.
Yeah, and it could just be that you ate something that didn't agree with you, and then, like you said, it has to be ongoing over 3 months, every, once or twice a week. We talk about the gut microbiome a lot and this gut-brain connection. What about if you've been on antibiotics for a long time because you had an infection and you've been on successive courses? Can that trigger IBS in people?
Yeah, I mean, we don't totally know, but the understanding that I have is that probably yes. So anytime you have an altered gut microbiome, you're going to have to try to replenish the stores of the good gut bacteria and try to reduce the amount of the less beneficial or harmful gut bacteria. And so when someone's on antibiotics for a long time, the gut microbiome gets kind of wiped out. So yeah, you're going to have disturbances to the gut microbiome and all the symptoms associated with that. And one of the things that people miss is they go on antibiotics. Maybe they think they're helping their gut microbiome by like immediately going on a probiotic, but they're missing the diet piece where you need to feed your gut with plants and fiber in
Yes.
order to repopulate the good gut bacteria. And so sometimes, it's interesting when you look at some other IBS protocols, sometimes the intervention is just reduce processed food, increase plants. Um,
Yes.
and that is, I mean, that's powerful for anyone who's been on antibiotics, not just people with IBS. But if you don't feed your gut the right types of foods, you're not going to have robust gut bacteria to help support your health. So
Yeah, so it's a domino effect, this interactivity that we've been talking about. When we talk about post-infectious IBS, I went on a holiday, I got food poisoning, I've never been the same since. I want to get some hard stats from you about this. How many people are affected by that situation?
a lot.
Do
It's
I need
thought,
to do I need to anchor myself to my chair again?
yes.
For this?
I mean, it's thought that 1 in 10 people develop IBS after food poisoning or traveler's diarrhea.
What?
Yeah. And we're seeing
Wow.
even more when people get infections that we don't understand a lot about, like COVID and other nasty viruses. It's not always just food.
Oh, yeah. What are the stats about that? About COVID related IBS? Is that another one of those gray areas? Wow.
Yeah, we're still learning. But I treat it the same way I treat food poisoning. It's a high
Yeah.
percentage. We don't know if it's 10%, but it's a lot of people who have ongoing digestive distress after COVID or having long COVID.
Mm. Ooh. So, wow. So let's go through a little bit of the science of why this happens. When we have an infection, we have food poisoning, we have pathogens that are affecting the balance of our gut microbiome. Take me inside of that a little bit more so we can
Yeah.
understand what's actually going on in our body.
Yeah, what's tricky here is, a lot of times the infection clears or it's not detectable, but the symptoms don't. So it's really frustrating. But yeah, I mean, basically you have this acute infection, which causes inflammation, alters the gut microbiome. Also, you're oftentimes taking medications alongside this, antibiotics very often to kind of wipe stuff out, especially when you've got like traveler's diarrhea or something like that. And there's these mast cells which are near the enteric nerves, and these are cells that are activated by your immune system, and they cause heightened nerve sensitivity and ongoing immune activation. So that you basically need to get that to calm down, those mast cells to calm down, and then also you need to get that nerve activation to calm down. And so some people, it resolves few weeks, few months, but some people it can take years and it can become chronic. And so how do you deal with that? We're still kind of learning a lot about post-infectious IBS. I think people didn't know this was such an issue until somewhat recently, the last 5 or 10 years. And that helps with treatment because it also helps us understand, okay, what could be causing these symptoms in the first place and what can we do about it? And I wish people would have, when they have this traveler's diarrhea, do more things to support their gut instead of just, kind of waiting it out and thinking these symptoms are just going to clear up on their own. I wish they would see dietitians to help them get through this.
Yeah.
We can help, and especially if it's not been going on for as long.
So if you're listening right now and you don't actually understand what a dietitian is, can we just go over that for just a minute? Because there is some misconceptions about the difference between a dietitian and a nutritionist and a health coach, and there's a lot of terms out there. Mm-hmm. What's the difference with it? Why do we need to be seeing a dietitian?
Yeah, well, dietitians are the experts in how to apply what we're eating to treat whatever medical condition is going on. We practice what's called medical nutrition therapy, and so we're doing a diet intervention to help inform a health outcome. And we have to go through thousands of hours of clinical training in a hospital. We have to take a test. We have a mandatory master's degree requirement. And a lot of times we even specialize. In the United States, we just came out with a new credential for GI dietitians, which is the CSDH credential. And I have that credential because I want people to understand that there are specialists in this. So yes. Even a dietitian's a better place to start, but the best is really a GI focused dietitian. And so now we have this credential to identify that.
Fantastic. I love that so much. So you have a medical license.
Yes.
That's
yes.
the fastest way I describe it to people. A dietitian has a medical license, just like any other medical practitioner, and you train in hospitals and learn how to work with other medical practitioners and all kinds of doctors and specialists, and you work on a medical team with somebody's doctor. Oh, I'm going to ask you more about this because it's such an important piece of this. But something that was coming up as we were talking was about SIBO, small intestinal bacterial overgrowth, which is so prevalent as well. And there is a lot of confusion between SIBO and IBS. So what are the statistics about the number of people you estimate are affected by SIBO? And just take me inside what you're seeing with this confusion.
Yeah, so SIBO stands for small intestinal bacterial overgrowth, and it's basically an inappropriate relocation of bacteria that should be living in the large intestine, and they kind of overgrow and move into the small intestine, and that causes a lot of unpleasant symptoms because you're still digesting and absorbing your food in the small intestines, and when those gut bacteria get in there before you can digest and absorb the nutrients, it's unpleasant. You get gas and bloating, oftentimes diarrhea or constipation. So again, things that look a lot like IBS, and sometimes nutrient deficiencies are present. So that's kind of an important distinction, is that sometimes you will see nutrient deficiencies like B12 deficiency with SIBO, which it tells you that it's probably not only IBS or even IBS at all. It could just be the SIBO that's causing those symptoms. So again, if you're working with a doctor who knows what they're doing, they're going to be testing you for nutrient deficiencies to see if that's a possibility. But the thing with SIBO is it looks a lot like IBS. And we're learning more and more about how to treat it and how to recognize it. The nutrient deficiencies is a big one. It's kind of like a differentiator, but sometimes people get diagnosed with IBS and they actually have SIBO. And it's very frustrating because they try all of the diet interventions, they try all of the other interventions, and it doesn't seem like it gets better. So big red flag for me is when we try a diet intervention for IBS and it does nothing. Or it does nothing. It just does not do what we expect it to do, which is give you significant relief. So SIBO is treated by medication, antibiotics, and diet interventions are not as effective for SIBO. Although, you can certainly reduce symptoms with diet interventions, but it's not going to be to the level we see with IBS because it's not really treating what the issue is. With SIBO, I find that people who get really full and gassy and bloated quickly after eating, and their symptoms start pretty much like right after eating, that's another one of the clues to me that it could be SIBO more likely causing the issues than IBS. But again, someone can have IBS and SIBO, and that's really...
Yeah, and we see that in our community, don't we?
Yeah.
food intolerances are on the rise. This is another area of your specialties. And that can trigger IBS. Is that correct? That's something that you can see. So tell me more about that.
Yeah, so food intolerances, it's kind of tricky because food intolerances don't necessarily cause IBS, but they can contribute to the symptoms of IBS. So if you, for example, get gassy and bloated after you eat beans, that's not necessarily a food intolerance or IBS. It's just kind of a fact of eating that food. Eating that food more often is not going to cause you to develop IBS. And a lot of people
that's an important distinction, isn't it? That is one of the big popular misconceptions.
Yeah, exactly. That FODMAPs can cause IBS.
Yes.
Now, food intolerances, and I see this a lot, that if you have a food intolerance and you continue to eat the food because you don't really know what's causing your issues, sometimes that can make your symptoms a lot worse, and it can make the symptoms difficult to calm down, reduce the flare, and so sometimes we see this overlapping GI distress then, and it's like, is it IBS? Is it a food intolerance? Sometimes it's both. We don't always totally know. So we have to do kind of a deeper dive and try out different things with diet in order to understand what's causing the problem.
And I think one of the key takeaways is that IBS is not simply a food intolerance issue or a food allergy issue. And this is a popular misconception that we see all the time in our community. Let's talk about hormones. Why do women get IBS more than men?
Yeah, I mean, we don't totally know, but there seems to be some thought that the estrogen and progesterone hormones that women have can directly affect motility and pain perception and can cause bloating. We know that our hormones fluctuate during the month when you have a menstrual cycle. That's why some people they might get very constipated prior to having a period, and then once they have their period, their progesterone drops and then they have loose stools. And so there's some natural fluctuations. Even when people are no longer menstruating, you still have sort of a natural fluctuation of hormones every month. And so yeah, I mean, I think it's probably related to this hormone fluctuation. We can't say that's true for everyone, like why that might affect one woman versus another. It might be really different. But yeah, it does seem like those hormone changes can affect, I mean, we know they affect motility, but also the bloating that comes with having a menstrual cycle very often, and then sometimes pain perception certainly.
It makes sense though, doesn't it? We know as women, whether you're menstruating or not, we are cycling every 30 days. And it's interesting to look at those fluctuations in hormones. But because there's over 150 hormones, and we talk about this with, GLP-1 and leptin and ghrelin, our hunger and satiety hormones, and insulin for our blood sugar, and adrenaline and cortisol for stress, and all these things, that our hormones affect our blood sugar, affect all kinds of things. And it makes sense then that those fluctuations in those sex hormones affect our insulin resistance and insulin sensitivity, I should say, and causing insulin resistance. It's much more common in women in perimenopause and menopause, and there's just the flow-on effect of all of it. And one of the things that's coming up for me as I'm talking to you is, what are you seeing in terms of IBS in people that are on GLP-1 medications? That are, they're injecting, it's hormone replacement, injecting a synthetic form of these peptide hormones, and how that's affecting all of their hormones and their digestive system, because it's, it slows down gastric emptying and all the stuff we know about these drugs now. What are you seeing with that?
Yeah, we're still learning. I think one of the biggest things I see is that motility is affected when people are on those medications, and so slowed digestion and all the symptoms that can come with that, sometimes feeling very full and bloated and gassy after small amounts of food. Constipation is a big one. So again, is it IBS, or is it just related to the effects of taking that medication sometimes doesn't totally matter. We're treating it the same way.
Yeah.
Because we know that some of the interventions we use for IBS, we're reducing the gas and the bloat by altering certain types of carbohydrates we're taking in. So sometimes that can be helpful for someone on a GLP-1, but it might not be the first thing I want to try when someone's intake is already limited because their appetite is suppressed. So
Mm.
it's totally changing the way I look at this type of diet intervention, because I think we can't be restricting as much as maybe we think that taking a certain food out of someone's diet will help. It's maybe not an appropriate thing to do, is to restrict more in that case. So.
Oh, I know you're big on restriction only when restriction is necessary. And that's one of the big things that we see, isn't it? People over restricting what they eat because of this analysis paralysis and this fear that they're going to have to go to the bathroom and have all these horrible symptoms. So let's talk about treatments. And there is a whole lot of things. So, and often it's a combination of things. So take us through that.
Mm-hmm. Yeah, so we're seeing more and more medications being developed for use in IBS, and I would say also for some of these other GI conditions like associated with medications like the GLP-1 medications. But there's like four main classes, which is like motility modulators. So when they're going to change they want to slow things up or slow things down or speed things up. Sometimes they're looking at secretion modifiers, so affecting the fluid movement in the intestines, which is helpful. You know, if someone's constipated, perhaps they need more fluid in the intestines. If they have very loose stools, we want less fluid. So those are some medications out there now. We're seeing some antibiotics and things that affect the microbiome. Rifaximin is a very common treatment for IBS-D and SIBO, and it's really to help restore healthy gut microbiome balance, and so that can be a helpful one. And then we're seeing more use of neuromodulators, which is fascinating because these are historically used as antidepressants. So the SSRIs and the TCAs, we are trying to lower the pain signaling. And so maybe it's a lower dose than someone would take if they were taking the medication for depression or anxiety or another psychological disease, but that calming down that pain signaling seems to help with certain symptoms. Now, I have people working with GI psychologists who, you know, maybe they should be taking these medications for other reasons, and then that treatment actually is better than what we're doing with diet or supplements or things like that. So sometimes you don't necessarily, like, I'm a dietitian, I want to do everything through food, but it's not always the best treatment for someone, although it's very often a supportive treatment, even if it's not the most effective one, right? Like you have to do diet with the mental health support.
Yes, yes. I'm definitely going to ask you about the diet intervention strategies, but I want to ask you about supplements first, because I know that in order to give somebody immediate relief, because they're so uncomfortable, I know that's why you would often maybe prescribe a medication with a supplement or something just to give somebody a few days of a reprieve from feeling miserable. What supplements do you recommend?
So we have a lot available to us now, and a lot of these are new, but they're so effective. And so again, like, I'm trying these supplements. It almost feels irresponsible as a dietitian to not try these supplements along with diet interventions, because it's like, if I can get someone relief without restricting their diet, I would like to do that.
Yes.
So peppermint is a big one. Peppermint is an antispasmodic. It helps calm that inflammatory cramping or constant, like, I guess it's like too much cramping that's associated with IBS and that abdominal pain. And so there are some great peppermint oil supplements out there where they're actually meant to, you swallow them, they don't break down in your stomach, they actually start to become activated in your small intestines, which is where you actually need the support to calm down those spasms. So that's a great one. Glutamine is another one.
Yes, I'm a big fan of the Metagenics glutagenics. Yes, it's just a gift from the gods.
Yeah, I mean, so glutamine is food for the the cells of the small intestinal lining.
Oh, that's a
And
great way to look at it.
yeah, it's like
It's
fuel, right?
food for the small intestine.
Yeah.
Yes.
So, I mean, it's an amino acid, but we see that this is really effective in people with post-infectious IBS because it helps restore the intestinal barrier. When you have an infection, glutamine is depleted. And so you need to build up your stores. And so there's a really good randomized controlled trial. It was a fairly small study, but I know that we're going to see larger studies soon. But they showed that when you took glutamine in 5-gram increments 3 times a day, so 15 grams total for 8 weeks, it improved symptoms. It reduced your bowel movement frequency, improved stool consistency, and reduced abdominal pain. So all the main problems with IBS-D, really, really important.
Wow.
Mhm.
And the incremental intake throughout the day, was that part
Yeah.
of the success of it?
Yeah,
Interesting.
I think so. I mean, because if you think about your body doesn't do very well with anything too much at once. And so I think spreading it out, like we always say, spreading things out throughout the day is going to help your body really
Yeah.
efficiently use what you're giving it.
Yeah. And it's so exciting to see glutamine embraced as a digestive health supplement because historically it's been used as a bodybuilding supplement. And we've been recommending, the Metagenics Glutagenics specifically for many, many years now, over 8 years. And what we love about the Metagenics Glutagenics is that it also contains aloe and licorice and other things that soothe the lining of the digestive tract from environmental pollutants and stress and processed foods and all kinds of things. And Megan, that is really considered the gold standard, isn't it, by gastroenterologists, digestive health specialists like yourself. I mean, it's a widely recommended supplement.
Yeah, absolutely. Especially if the goal is calming digestive distress. I mean, people can certainly take other forms of glutamine, but I would say that the most effective way to calm your symptoms down, if gastrointestinal distress is an issue for you, that's the best supplement for sure. But if you're just doing some maintenance glutamine supplementation, maybe you don't need that product in particular.
Yeah, and sidebar, if you suffer from acid reflux or GERD, it is a godsend, that supplement. Let's talk about digestive enzymes because that's another area where it's getting very exciting, where there's targeted enzymes that can help for IBS.
Yeah, this is one of the best things that's developed in the last few years, I think. I mean, there are a lot of enzymes out there now which are targeting specific types of foods that are more problematic for people with IBS. So we'll talk about dietary triggers and FODMAPs, but when you think about digestive enzymes and what some of the challenges that people have is that they're having too much of something and they're not able to break it down. Digestive enzymes help you do that. And so there's great products out there now that are targeted at some of the more common FODMAPs. Specifically, well, we know that most people with IBS have trouble with 2 FODMAP categories, fructans and galacto-oligosaccharides, which those are your garlic, your onion, your wheat, your beans, your cruciferous veggies, leeks, asparagus. Like these are the foods I think people a lot of times are like, oh my gosh, I can never have those again. But
And they're some of the most powerful detox foods, health promoting foods. They help to, the body detox excess estrogen. I mean, we need to be eating these foods. And,
yeah,
asparagus is a powerful prebiotic and all the things we know. I mean, this is the tough thing about this stuff. And that's why we don't want to get into that analysis paralysis and be restricting it for too long because these foods are so powerful.
yeah, and I mean the enzymes make it so that you can have some of these foods and not have as many symptoms because it's helping you break down the foods. And so if you know that there's certain types of foods that trigger you, you want to look for a digestive enzyme supplement that contains the enzymes that are going to help support the breakdown of that food. And so alpha galactosidase is the enzyme that helps break down galacto-oligosaccharides or GOS on the FODMAP chart.
God, I'm glad you're throwing out those terms because that's not rolling off my tongue.
No, they're not easy names. And then inulinase and fructan hydrolase help break down fructans. So your garlic, your onions, your leeks, your asparagus, your cabbage, all those delicious foods that are strong flavors. So those are the things you want to see. And there's some great products out there now. There's a number of them. I really like the FODZyme brand and
Yeah,
the
that's a good one.
Coloring brand. Those are great
Mm.
products to try. Yeah.
Mm. Yeah, and our body produces enzymes, but we produce less of them as we age. So digestive enzyme supplementation could be a prudent choice for you if you're over 40 specifically. Let's get into dietary intervention, because this is such a huge piece of managing IBS. I want to start with this food anxiety, though, that we've been talking about, that is such a big piece of this, and how we find that balance of attending and managing and figuring this out without diving into over-restriction.
Yeah, I mean, digestive distress can exacerbate psychological stress, and psychological stress can exacerbate digestive distress. And so this gut-brain connection is something we have to get at. What is really distressing to me as a dietitian is that a lot of people, they feel better, they think they feel better by cutting out certain foods. They cut out, maybe they cut out gluten and dairy and they feel better, and that's very common with IBS, by the way. But then, they cut out all kinds of other foods that are really health promoting foods, things like garlic and onion or cabbage, things we want people to be able to eat. And then their food list, all of a sudden, it's very small. And I've had people come to me, they've sort of been doing this journey for a long time, and they have maybe 5 to 10 foods that they're eating on a regular basis with very little variety. Yeah. Yeah, and that's a problem. I mean, you're trying to control your symptoms by further restricting your diet. It can turn into a very intense food fear and eating disorder. I mean, we see this happen to a lot of people. But on a physical level, you're not going to have enough nutrients, so you're going to develop nutrient deficiencies. Your gut microbiome is going to be disturbed, and your symptoms are very likely going to be exacerbated by that heightened gut-brain connection distress, and it's a vicious cycle that keeps going. So
Yeah. Whew. So we talked about FODMAPs, and you throwing out all of those terms that none of us can pronounce except for you. The low-FODMAP diet is the number one intervention strategy for IBS. So let's talk about what FODMAPs are and how this protocol came to be.
Yeah, so FODMAPs, it's an acronym. I can say the acronym. Should I say it?
Oh, please do again, please, because it's like my favorite sport is watching you say those terms.
Yeah. So FODMAPs stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. And all that really means is carbohydrates that cause a lot of gas and bloating and are difficult to absorb. So, yeah. And so, again, there's different categories of FODMAPs. Every word I just said in that acronym kind of represents a different category of carbohydrates, but we do have, like the main categories are fructans, galacto-oligosaccharides, lactose, so dairy products, and then sugar alcohols. People who are eating a lot of non-nutritive sweeteners, sometimes that's the easiest thing I can fix. If I see someone who's using a lot of non-nutritive sweeteners, I'm like, that is where we're starting.
Yeah, and they're so prevalent in everything, sugar-free everything. I mean, so many people are taking in these non-nutritive sweeteners.
Yeah. So the way the FODMAP protocol works is we want to reduce FODMAPs in the diet, try to calm down symptoms, and then we want to try to reintroduce them or challenge them in a very slow and systematic way so that we can understand what's really triggering symptoms. And then we're hopefully going to personalize it by using some of these other tools I mentioned, digestive enzymes, or really specific combinations of foods we'll create sometimes. So I always have like a do not combine these types of foods list. And, that's all part of the personalization phase where we're working to get someone towards the most varied and liberal diet as possible without triggering their symptoms. But it's important for people to know, like the low FODMAP diet or the FODMAP protocol is not a cure for IBS. It's a treatment for symptoms. And so when someone's eating a high FODMAP food, they're not causing damage to their intestines, but they are triggering symptoms. And so this personalization phase has to be done with a dietitian, because I have a friend who's a gastroenterologist who she always says IBS is kind of like, is it worth it? And there are instances where I think, maybe it is worth it to have something, take a supplement to calm down your symptoms. You just want to know. A lot of this is about discovering what is the trigger for you so that you can live your best life and move forward in a way that makes sense for you. I have people who, garlic is like, they need it. They want to eat it.
Yeah, that would be me.
Yeah. Yeah.
I often think this. If I found out I had IBS and I couldn't eat onion and garlic, oh gosh, I would really struggle with that. I would do it.
Yeah.
I would do it.
But so what do? We have a lot of solutions, right? We can do digestive enzymes. We can give peppermint. We can, there are cooking techniques where you can infuse oils and cook your food in garlic infused oil, but you're not actually getting the problematic properties of the garlic. So if I know that's your trigger, I can give you a lot of tips, but we can't understand whether or not that's a necessary intervention for you unless we go through this protocol. And more we're starting to, or a lot of trained Monash dietitians are starting to look at people's food journals, looking at what types of foods are commonly in their diet and seeing if we can get relief by just changing certain things. I said before, like non-nutritive sweeteners, if I see that, like I'm pulling those out immediately and seeing if that gives me a change. But sometimes it's just, a few things, but if you're eating them every day, that's really what's driving the symptoms. And so it takes someone who really knows what the foods are in the low FODMAP protocol, but then also understanding that like there are certain things that are just not supportive for quality of life and we need to do something different. And so we got to get creative sometimes.
Yeah, using the protocol in a way that serves you and your lifestyle and fits you and your personality and is actually doable. So Meghan and I did an episode all about the low FODMAP diet and protocol and all of the misconceptions, because the biggest one is that it's a long-term diet that you can be on. It is a short-term intervention strategy, and there are all kinds of problems, nutrient deficiencies and food disordered eating being the two big ones. But Meghan and I did a whole deep dive, hour-long episode about the low FODMAP diet, and I will put the link to that episode in the show notes if you want to go and listen to get a lot more information about the low FODMAP protocol. But I will just say, in case you're never going to go and listen to that episode, that Meghan just alluded to, just named Monash University. So Monash University is in Melbourne, Australia. And as an Australian, can I just be a bit parochial and just say we're very, very proud that it was discovered and developed in Australia, and it is now just a worldwide intervention strategy. And Meghan is a Monash University certified FODMAP practitioner. And so they're the people that you want to go and work with if you're going to embark on the low FODMAP diet journey. And obviously you can go and connect with Meghan at nutmegnutrition.org. She's amazing and does telehealth. I'll just give you a great shout out there, Meghan. I want to ask you about bloating, because they kind of call it the bloating dilemma or the bloating conundrum or the bloating maze or the bloating puzzle, that bloating can be caused by so many different things, and most people are experiencing bloating on a daily basis, whether we have IBS or not. So I just want to ask you for a little bit more information around that, because I know that you treat people with bloating all the time, and I think that that's another misconception that I just want to make sure we cover.
Mm-hmm. Yeah, bloating it's a tricky symptom because there are so many causes of bloating. So bloating is when it's kind of that sensation of heaviness. It's when there's excess. You kind of feel extra gas and water in the intestines and that heaviness in the gut. And It can certainly be caused by diet. There are certain foods that are always going to cause bloating. It can be caused by constipation. It can be caused by gas buildup, or the sensation of it can be caused by gas buildup. It can be caused by motility issues, pelvic floor health problems. If you're not moving your body very much, it can be a trigger for bloating. Nervous system distress. So there's just so many causes of bloating. That is, I think, other than IBS, it's probably something that I get more referrals for, and people don't often realize it's more of a symptom of something else going on than a condition itself. So sometimes
Yes, such an important distinction.
like they'll
Yeah.
realize that they've had a pelvic floor problem for
Oh,
since
yes.
we had children, and now we have bloating and gas and constipation, and it's really not a diet issue, but diet can certainly help. So yeah.
Yeah, I did a fantastic episode with Dr. Tanya Goodrich, who is a pelvic physiotherapist. And she talked about this very thing about how all of our plumbing down there is connected. So when there's a problem with one part of the plumbing, it affects all the other plumbing in the house. So when you've got pelvic floor issues, it can cause digestive issues. It can cause bladder issues. It can cause, sexual health issues. And it's really interesting. So if you want to go and listen to that episode, it is phenomenal about pelvic floor issues. And then she moves into bone health and osteoporosis. It's just jam-packed with fantastic information. So I want to ask you about stress, because stress management is such a huge piece of managing IBS. So what are you seeing around this?
Yeah, I mean, it often has to go hand in hand with any diet intervention we're doing. So, medications are very often part of this. We see GI psychologists, which is a whole specialty, by the way. A lot of people don't know that they have psychologists specializing in
Wow,
gastrointestinal health.
very
Yeah,
exciting.
yeah, so sometimes medication management is part of it, but we also have a lot of other strategies that a dietitian can recommend. We're not necessarily the experts in them, but we know they can be good adjacent therapies if you don't have access to a GI psychologist. So there's gut-directed hypnotherapy, which can help support changes in gut sensitivity. And then there's cognitive behavioral therapy, which can help with nervous system regulation. And there's apps actually out there that have both of these. Mindset Health is a great one that kind of has two tracks, and you can sort of determine which one is the right one for you. And it guides you through exercises that are either gut-directed hypnotherapy based or cognitive behavioral therapy based. And so those can be great resources.
I mean,
And
you recommend this all the time, don't you? And what's so exciting about this is that hypnotherapy and cognitive behavior, it used to just be considered this hippy dippy weird thing that you wouldn't touch, and mainstream medicine was like, ugh. Now people are getting such extraordinary results that mainstream physicians and dietitians like yourself are actively telling their patients to go and do this because the results are so extraordinary. So just talk us through what you're seeing as a dietitian with this.
Yeah, I mean, they can be just as effective as diet interventions. We see this in people where stress is a trigger for their symptoms.
Whoa.
Yeah. Yeah. And I mean, it doesn't have to go so far where you're seeing a therapist for this, although I think that's great. If you do, I think that, a psychologist can be really helpful. But breath work, making sure you're sleeping well, other things that calm down your nervous system. For some people, it's exercise. For some people, it's just meditation. Like, you don't have to necessarily go full in on some of this stuff, but these are the most evidence-based treatments that we have. And so I recommend, especially if I think someone's symptoms are triggered by stress, or a stressful event triggered their IBS sometime in the past, I think this is imperative. I use it with everyone. I'm always talking to my clients about stress and how to handle stress in their life. And even if I'm not the person that's going to solve that, I can give them the tools to help support their journey. What I find is that a lot of people, they want cutting foods out of their diet to be the answer, and it's just not sometimes. And so I like people to, people get afraid of eating because they've been on restrictive diets, and they're afraid to reintroduce these foods, and they think that that's going to cause the symptoms, but sometimes it has nothing to do with that. And it's this GI psychology field is amazing for those people.
It is extraordinary, isn't it? And stress is the keynote address, isn't it? At most of the gastroenterology conference, the digestive health. I mean, all health conferences. I spoke to a cardiologist the other day and, stress. And even though we hear it all the time and we know it, we still ignore it. And so what I'm hearing from you is that it's a multi-prong treatment plan that you're helping people put together in consultation with their practitioner, that it's not just one strategy, that we've got a whole buffet of options on the table and we can, keep trying different things to find, a cohesive, comprehensive treatment plan to manage this condition.
Yeah. And that's amazing because the developments in the last few years have gotten us to this point. We used to only have the low-FODMAP diet, which is an amazing diet, but it's not the right approach for everyone. So now we have all these things. We have supplements. We've got stress-based therapies. We've got all kinds of diet interventions. We've really evolved, and it's great because it gives people options.
Oh, yeah, you must be so excited as an IBS specialist about the next frontier, what's coming in the future too.
Yeah, and I think we'll get more personalized. Like maybe we will in the future have a test for IBS that allows us to make a very specific diet recommendation. That'd be amazing. I mean, we don't have that at this point. Anyone who tells you there's like a food sensitivity test that's going to tell you exactly what's triggering your IBS is not scientifically accurate. But, maybe in the future, I think that would be amazing and very helpful.
Oh, so exciting. And because you are on the forefront of all of this research into autoimmune protocols at the Celiac Disease Foundation, you've got access to all of the latest science and studies and practitioners and what they're doing. And it's just so thrilling. And I know we're all geeking out about it on our weekly calls on Skinny 60. Okay, what did you learn this time? What did you learn at this conference? What's going on? It's so fantastic to have you as a resource. I want to ask you about IBS and weight management, because this is another area where there's a lot of misconception, misinformation, anxiety, stress around that, and particularly women over 40 and perimenopause, menopause, postmenopause who are really struggling with weight issues.
Mm-hmm. Yeah, I always treat IBS as sort of separate to whatever weight someone is. So I'm treating the symptoms as they are with the diet interventions I would use for someone of any shape and size. But if someone has existing shape and size, body image related concerns and anxiety about those things, then, I'm probably not going to put them on a restrictive diet. None of these conditions inherently cause someone's weight to go up or down, but restriction can. And sometimes people perceive bloating and distension as weight gain. They say, I look like I'm so big in the abdominal area. I look pregnant. I hear that all the time. And it's not like you're gaining weight, but you are having a physical response to something related to your IBS. And so I think it can be challenging to get at that. Someone's hunger fullness cues could be altered by the fact that they are going through psychological stress or that they're having appetite changes and maybe restrictions because of that. Chronic stress can raise cortisol, which can affect your appetite regulation and also your blood sugar control. And I find that so many people end up in a position where they're actually not eating enough, but they don't perceive that as a problem. They see it as, kind of a means to an end, or this is the only way they can control their IBS symptoms, for example. And so it's a big problem. And so honestly, getting someone to nourish themselves adequately has to be part of this, or we can do all the diet restrictions in the world, but your symptoms are not going to go away because your body's metabolism is not functioning properly. And so I have to get people eating more often, very often. I had to get them eating every 3 to 4 hours more regularly throughout the day so that they can at least not have, and also going long periods without eating can cause symptoms that feel like IBS. It can cause bloating. It can cause
yes.
It can cause reflux. It can cause nausea. So sometimes that's a big hurdle, and it's more important than limiting FODMAPs. I'm not going to do a FODMAP restriction in someone where I think maybe they need to nourish themselves first. So first thing is adequately nourishing yourself, and then we'll get into restrictions where appropriate if it's indicated.
Yeah, I mean, we talk about this all the time in our community, don't we? We've spoken about it on several episodes of the podcast together, is most women are undernourishing themselves and not eating enough, whether you have IBS or not. If you are not eating every few hours and only eating 1 or 2 meals a day, your body just cannot function at optimal levels. So this is why we have the PACE strategy in Skinny 60, don't we? It's pacing our intake of food and caloric beverages throughout the day. It's just better for digestion, better for your mental health, better for your mood stability, your hormones, your blood sugar, your gut health, everything. So, and also it's just more joyful. I mean, Meghan and I like to eat, don't we? So it's just have fun with your food, you know. So even more important to work with a dietitian like yourself, who one of your many superpowers is meeting everybody where they're at, getting to know, a good practitioner will get to know you and your lifestyle, what you like to eat, who do you live with, do you have kids, do you have elderly parents, where do you work, how do you work out, all these, what foods do you actually like? All these things play a role in formulating strategies and a plan that will work for you and actually be sustainable. And that's what Meghan does. This mental health piece is so key to this with any medical condition, whether it's IBS or something else. So what do you see as a dietitian the biggest obstacles with that, and the things that that help alleviate some of those problems?
I mean, we have to be treating the nervous system in order for any diet intervention to work. And so reducing anxiety and depression and health anxiety, of course, but it's also what you said before about meeting someone where they are. I am not going to make a recommendation for someone to follow a specific diet protocol if I don't think they can actually do it. So a lot of times those other things they're saying, about their cooking ability, their time, their family situation, their willingness to put in meal prep, that goes with the mental health piece, because it's not helpful if I make a recommendation that you can't follow, and then it adds to the anxiety and the stress. And so sometimes it's very simple things, and people will sometimes get a little frustrated. They're like, I thought I was going to be doing a whole overhaul, and my response is always like, that is not appropriate if you can't do it. And so another reason why working with a dietitian who understands the nuances of the low FODMAP diet and other diet interventions for IBS, where we're looking at, okay, like, can this person actually restrict this food or actually do this eating plan that I'm recommending? And if not, what can I do to help them along? And that reduces anxiety and food fear, I find, a lot of times. And sometimes,
and also just self-esteem, feeling like you're not failing, or you're not cutting the mustard or meeting the mark, or I'm doing less than, or there must be something wrong with me. Just going with the flow of what is. And again, that's another one of your strengths. And I see that every day in Skinny 60, you helping people and meeting them where they're at. Oh gosh, I could talk to you about this for 5 hours. It's just such important stuff, and this affects so many people. So let's do a bit of a recap, if you don't mind. What are the most important things that we need to know about IBS?
I mean, I think the definition that it is a disorder of the gut-brain interaction helps reframe it in a way where it's not necessarily a diet issue. Food can be a trigger, but it's not the cause. It's a gut-brain disorder. And so stress matters more than people realize. Over-restriction can worsen it. You want to improve the health of your gut and your intestines and reduce symptoms in a way that is not stressful. And that requires personalization and really understanding where we can make the most appropriate changes for you when it comes to IBS. So oftentimes it's not just a diet intervention, which people they don't understand. They see online low FODMAP diet, low FODMAP diet, low FODMAP diet, and they miss the other stuff. And it's the low FODMAP diet can only get us so far with some people. So.
Yeah, and I just want to go over the things that we're getting wrong. I hate to say it like that, but some of the most common mistakes, let's put it that way, that people are making. You alluded to searching and making generic conclusions that may not apply to you, but what else are some of the mistakes that we may be making?
Well, not working with a provider that's testing you for other conditions. I mean, the amount of people who are self-treating their IBS and then they find out they have something like celiac disease is alarming. So you've got to be working with a doctor who's testing you for all of the other stuff. So going on a restrictive diet forever, going on a low FODMAP diet long term, it's not appropriate. Cutting out fiber or gluten completely without understanding whether or not those are really triggers, ignoring stress, assuming certain supplements will just fix everything. The amount of supplements on that list are too long to name, but thinking something like a probiotic or some other crazy supplement that's like a GI health blend that has all kinds of stuff in it, and just assuming that's going to help you.
And just going gluten-free. That's a huge one that we see, don't it? Well, I'm gluten-free, dairy-free, and sugar-free.
Yeah.
They're just isolated strategies.
Yeah, exactly. So you're not really getting at what's causing the problem. And so how do you fix that? You've got to work with people who know what they're doing in this space and can help you navigate that.
Yeah, and when people are hyper vigilant and really aware and educated and are still not working with the practitioner, it can actually get in the way of the diagnosis. We see this all the time, don't we? Where people are gluten-free, dairy-free, sugar-free, they're eating fermented foods, they're eating lots of vegetables, and it puts a Band-Aid and masks the symptoms. And then you go for years and years and years. You see that all the time with people not being diagnosed with celiac disease because they've been gluten-free for so many years.
Yeah, and especially in the celiac disease space, we have a lot of great studies showing that hypervigilance reduces quality of life. So that's an important consideration.
Ooh,
Yeah.
gosh, we could do a whole episode about that, and we may. Oh, okay, I'll put a pin in that for right now, but that's piqued my interest because, wow. Yeah, and I fit into that category. I would absolutely put myself in that category sometimes, for sure. So we talk about the importance of having a good medical team. What are your recommendations for where we find practitioners, doctors, dietitians, GI therapists, all these people that you've named? How do we assemble a great medical team of people that understand IBS and can help us manage it?
Yeah. Well, from a dietitian standpoint, the Monash University app has a great list of dietitians who are IBS specialists. You can also look for that. It's CSDH credential after someone's name. It stands for Certified Specialist in Digestive Health, and that's a new thing in the United States where we have a credential specifically for GI conditions. So that's a good clue. And then, I think the American Gastroenterology Association has a good list. The Canadian Digestive Health Foundation, the International Foundation for Gastrointestinal Disorders. There are a lot of these resources out there now, so those would be my go-to places. There are also a number of great GI psychology resources. There's a GI psychology website. I believe the website is just gipsychology.com, but you can always look for good GI psychologists that way. And then a gastroenterologist is going to be the doctor that specializes in these conditions. Your primary care doctor, your general provider, they're just not going to be the experts in this. And so you got to be working with someone with a gastrointestinal specialty.
Thank you so much for all this valuable information, as always. You can connect with Meghan at nutmegnutrition.org. But gosh, I cannot wait, like a year from now, 2 years from now, doing a follow-up episode about this with all of the new studies and information, because it's such an emerging field, and what you and your colleagues are going to be learning about this. It's a really exciting time.
Yeah. Absolutely. I think it's changed so much since I've become a dietitian, and I expect that will continue. So it's really exciting.
So much great information. Here are the top line takeaways. IBS affects 10 to 15% of the population in the United States, and the condition is more common in women due to hormone fluctuations. And the symptoms to look out for: bloating, gas, abdominal pain or cramping, diarrhea or constipation or both, an urgency of needing to go to the bathroom, a feeling of incomplete evacuation, seeing mucus in your stool. If you have any of these symptoms every week for a few months, please see a gastroenterologist. But IBS does not cause bleeding or weight loss, anemia or fever. So if you have any of those, please get your doctor to test for other things. And in order to get diagnosed effectively, there is no biomarker. An IBS diagnosis is based on symptoms. There's no blood test, and it doesn't show up in a colonoscopy or an endoscopy. A gastroenterologist will look at your symptoms, test for anemia, look at inflammatory markers, and test for celiac disease, Crohn's disease, ulcerative colitis, IBD, and colon cancer. So those conditions are inflammatory or structural diseases. IBS does not cause damage to the intestines. However, a good doctor will test for all of those things to rule them out first in order to get to an accurate diagnosis of IBS. And because there's a lot of crossover symptoms with digestive conditions, it can take months to get an accurate diagnosis. So just be patient and work with a really good practitioner to get to the right solution. And also that important note she was making that you could have any of those conditions and also have IBS. There could be excessive inflammation in your intestines. The difference between SIBO and IBS, they look quite similar, but you've got to get that accurate diagnosis because SIBO is treated with medication and dietary interventions are often not as effective. And knowing the type of IBS that you have, the subtype guides your treatment plan. So it's important to look at those patterns. So IBS-D is the diarrhea predominant kind. You've got that urgency, the loose stools. IBS-C is the constipation predominant. So you've got infrequent bowel movements, straining, incomplete evacuation. And then IBS-M is the combination, alternating diarrhea and constipation. It's often the most frustrating one because it's quite unpredictable. And the causes of IBS, do not overlook stress. The stress that can cause these digestive symptoms and irregularities in the gut-brain connection because of stress or trauma, foodborne illnesses, or persistent use of antibiotics. 1 in 10 people develop IBS after food poisoning or traveler's diarrhea. So if you get sick while you're traveling, it's really important that you repopulate your gut with the beneficial microbes. And a lot of people are having ongoing digestive distress because of COVID. So just be mindful after you've had COVID to just be really paying attention to your digestive health. And noting those misconceptions about food intolerances, that IBS is a disorder of the gut-brain interaction, not necessarily a diet issue. Food can be a trigger, but it's not the cause. And food intolerances and FODMAPs don't necessarily cause IBS, but they can contribute to the symptoms of IBS. And really noting that the common mistakes that she was talking about. Please don't consult with Dr. Google. Self-diagnosing on the internet without ruling out other conditions with a medical team is the biggest mistake. You can Google and use ChatGPT to go, oh, gee, what might I have? But then you got to go and see your doctor to get an accurate diagnosis. A lot of people are going on the low-FODMAP diet thinking that's the answer to everything, and it could be over-restrictive. You may not necessarily need to go on that. And then a lot of people are going on the low-FODMAP diet long-term when it's supposed to be a short-term intervention strategy. Taking supplements that you find on TikTok or Instagram or the internet, it can actually worsen the symptoms. Avoiding all fiber, which is a common mistake, can actually make symptoms worse. You've got to be taking in the right kinds of fiber for your needs and ignoring stress. It's the number one cause of IBS and people don't realize it. So the dietary intervention strategies, often, as Meghan was saying, removing processed foods and just including more plants is often the strategy. Removing gluten, dairy, sugar, non-nutritive sweeteners is another one. The low-FODMAP diet, like I said, it's not a cure for IBS, but it's a treatment for the symptoms and can identify potential trigger foods. So if you want to listen to the deep dive that Meghan and I did about FODMAPs and the low-FODMAP protocol, go and listen to episode 78 of the podcast. Her point about eating smaller meals and snacks, balanced meals and snacks more frequently is a really salient one, and it's applicable for everybody, whether you have IBS or not. Chronic stress raises cortisol levels, our primary stress hormone, which can affect your appetite regulation, your blood sugar control. And most people are not eating enough, and it impairs metabolic function and impairs and interferes with your digestive health. So eating every 3 to 4 hours, a balanced meal and snack with some protein, fats, and carbohydrates. It's better for your digestion, your blood sugar, your hormones, your mood stability, your sleep and energy, and definitely your weight management. We see this all the time in Skinny 60, where most women just aren't eating enough. And when they start eating more, they start losing weight and feeling better. And it's really quite extraordinary. The supplements that she was talking about could be really effective. The peppermint oil acting as an antispasmodic. Glutamine, particularly the Metagenics Glutagenics, is really the gold standard for glutamine, is really effective for post-infectious IBS. The different digestive enzymes that she was talking about, FODzymes and some of those other brands, and the medications. And there's more and more that are being developed because IBS is so common. So the secretion modifiers, where it affects the fluid movement in the intestines to alleviate constipation or diarrhea. The gut health meds to help restore the healthy microbiome. Neuromodulators that have been typically used as antidepressants can lower pain signaling, which helps with certain symptoms of IBS. And working with a GI psychologist to manage your stress. So the gut-directed hypnotherapy, which supports changes in gut sensitivity, the cognitive behavioral therapy, which helps with nervous system regulation. So Mindset Health is a really great resource where they've got a track that's focused on gut-directed hypnotherapy and then one that's focused on cognitive behavioral therapy, and just simple breath work that you can do for free. There's lots of different apps for that where you can just calm and regulate your nervous system. But the important point is working with expert practitioners to develop a holistic intervention plan. So having a gastroenterologist and then having a dietitian who specializes in IBS and digestive health like Meghan. So putting those two practitioners together, they can really help to reduce the health anxiety and develop the least restrictive plan that's realistic for your personality and lifestyle. That a treatment plan requires a multi-prong approach. It's not just one strategy. So there's a lot of things on the buffet, as she said. So the point that she was making about the nervous system, that you've got to be treating your nervous system for any dietary intervention strategy to work. And so stress is just inextricably linked to the health of our body, particularly our digestive health and that gut-brain connection. So to find good practitioners, the Monash University app has a great list of dietitians who specialize in IBS. Look for that CSDH credential, that new credential that's a certified specialist in digestive health that Meghan has. Going to the American Gastroenterology Association if you're in the United States, the Canadian Digestive Health Foundation if you're in Canada. There's an international foundation for gastrointestinal disorders, and going to gipsychology.com. They're all great resources. And of course, you can contact Meghan directly at nutmegnutrition.org. She does telehealth. She's a fantastic practitioner. As I said, I've been working with her for over 7 years. She has helped thousands of people in our community achieve better health, and she really listens and helps you find a holistic approach that works for you and your lifestyle. So definitely check that out. I'm really curious to see if you have IBS, someone in your family, what you've been doing to manage it. So definitely leave a review or a post in the Facebook group. I'm interested to hear your story.
I want to hear about your It Has to Be Me story. So head on over to ithastobeme.com/stories to share it in our free community. You can also join the conversations we're having about this episode and others. I'm Tess Masters. Join me next week and we'll dive inside another great story to help us go from dreaming to doing.